Değerli konuklar, iyi akşamlar. Ben Doktor Özgür Öktem, Koç Üniversitesi Tıp Fakültesi Kadın Hastalıkları Doğum Anabilim Dalı'ndan. Üreme Sağlığı Derneği olarak şahsım ve yönetim kurulu adına hepinize hoş geldiniz diyorum. Bugün ilk defa yapacağımız Masterclass in Reproduction serisine başlıyoruz. Bu seride üreme tıbbının farklı disiplinlerinde, bu bir sistem biyolojisi olabilir, bir hastalık olabilir, bir hormon olabilir. O konuda dünya çapında reputasyona sahip bir bilim insanını davet ederek konuşturacağız. Bu konuyla ilgili o spesifik artık hastalık ya da sistem biyolojisiyle ilgili bir organ ya da hormon her neyse o konuyla ilgili bizi güncel veriler ışığında aydınlatacaklar. Bu serinin ilk konuşmacısı Doktor RICARDO AZZIZ olacak. RICARDO AZZIZ hepinizin bildiği gibi polikistik over sendromu konusunda dünyada en sayılı duayenlerden biri demek herhalde yanlış olmaz. Bu konuda son derece kıymetli klinik çalışmaları var. Kendisi aynı zamanda Amerikan Üreme Tıbbı Cemiyeti ASRM'nin de Chief Executive Officer olarak çalışıyor, CEO'su. Aynı zamanda State University of New York Albany'deki kampüste de kendisi öğretim üyeliği pozisyonuna devam ediyorlar. Kendileri bizi kırmadılar. Çok teşekkür ediyoruz. Davetimizi kabul ettiler. Bugün kendileri benim giriş konuşmamın ardından konuşmasını yapacak. Konuşmasının sonunda da sorular ve yanıtlar kısmını bizim derneğin yönetim kurulundan Profesör Doktor Kayhan Yakın ve Profesör Doktor Aylin Perinçil modere edecekler. İngilizce bilmiyorsanız bu sorun olmayacaktır. Çünkü Türkçe altyazıda mevcut olacak. Dear guests, welcome to the first meeting of our Masterclass in Reproduction series here. Our first speaker will be Dr. Ricardo Aziz from USA. As you all know, he is one of the top leading experts in this polycystic ovarian syndrome. Today he will be talking about polycystic ovarian syndrome. And at the end of his talk, he will be connected with us and will be available live for the question and answer sessions. Thank you very much, Dr. Aziz. It's great to have you with us. Teşekkürler.
Like this, where we're all still very far removed because of the pandemic, certainly I feel privileged to be able to communicate with you across the ocean.
In the next 20 minutes or so, I'm going to provide you with some new updates on the diagnosis and epidemiology of PCOS. And then we'll hopefully have some questions as well. So let me just start out by simply stating what most of us already know, right? And those of you who will be participating will be able to learn about the epidemiology and public health significance of PCOS, learn to evaluate and phenotype those patients suspected of having PCOS, and evaluate for metabolic complications. Now, if you study a large group of unselected women with androgen excess, often hirsutism, but other signs as well, you'll find that the vast majority of these women will have polycystic ovary syndrome. This is a study we did a number of years ago, again from our clinic, and you'll see that about 7% of the women that we saw had specific conditions. You know, they had tumors or adrenal hyperplasia and so on and so forth. About 93% of them had functional androgen excess, of which the vast majority was polycystic ovary syndrome. So in general, we consider that the vast majority of patients, about 90% or more, will suffer with polycystic ovary syndrome. Somewhere between 7 and 10% of women with androgen excess will have other disorders that are not polycystic ovary syndrome. Now, polycystic ovary syndrome is often there's often confusion around polycystic ovary syndrome depending on the definition used, etc. But I think that in fact today we very much clarified that in fact the definition is less important than the phenotypes that you're using. So just to give you some impression, in 1990 the NIH had a conference. They came up with a definition that stated that PCOS had to include hirsutism, ovulatory dysfunction, and those two conditions then created two phenotypes, if you would. In 2003, we had a meeting in Rotterdam, again, another expert meeting. They expanded the definition of PCOS. And finally, the Androgenetics and PCOS Society in 2006, comparing and looking at the metabolic complications of PCOS, stated that there was only 3 phenotypes. But what you see is that each of these represents an extension of the other. NIH is the strictest, Androgen Excess and PCOS Societies is the second strictest, and Rotterdam is the broadest of the definitions. But when you look at phenotypes, what you see is the following. Phenotypes A and B are what we call classic PCOS. They include patients with hirsutism, ovulatory dysfunction, who may or may not include polycystic ovaries on ultrasonography. Phenotype C is what we call hyperandrogenic or ovulatory PCOS. And this is, again, patients who have evidence of hyperandrogenism, polycystic ovarian morphology, but normal ovulation. And finally, phenotype D are what we call the non-hyperandrogenic PCOS. These are patients who have identify patients with possible PCOS, and that is individuals who have signs or complaints consistent with clinical hyperandrogenism. Again, the patient's complaint alone is sufficient for this, so it's important to remember that. And the second one is to have a history or complaints, again, suggestive of ovulatory dysfunction, usually irregularity in menstrual function. Again, the patient's complaints are sufficient to qualify these patients for possible PCOS. Now, this is a study that we recently published last year, and what you'll notice is that we asked patients really just these 2 questions, and the positive and negative predictive value was very, very high relative to the accuracy of self-reporting male hair growth and the accuracy of self-reporting oligomenorrhea. So again, asking questions, just these 2 simple questions for patients, allows you to identify those patients that are in need of being evaluated for PCOS. Again, if they have any complaints or signs of hyperandrogenism, or if they have signs, history, or complaints of irregular menstruation or irregular ovulation. Now, to evaluate patients with PCOS, of course, it is in patients who are hyperandrogenic for PCOS. It does require a full history and physical. This is not just a sort of, I'm going to look at your chin kind of thing. You have to do a full physical exam. You have to obtain a full history. This is a medical condition, right? It's not just simply an abnormal pap smear, if you would. So it's important that you actually focus on the full patient. We use the modified Ferriman-Galloway score to determine, the amount of terminal hair growth in women. I think this is important to remember. When you're looking for hirsutism, you are looking for presence of terminal hairs in areas that are primarily masculine. Terminal hairs are those hairs that are thicker, they tend to grow longer, they tend to be pigmented, they tend to have a shape. But more importantly, if you put them under the microscope, if you squish them between 2 pieces of glass under the microscope and you look under just a regular light microscope, you will see that it has a medulla, a soft core of cells within the hair. That's what terminal hairs have. They look like bone marrows, if you would, so that the center core of a terminal hair has a soft marrow, or medulla, as we call it. Villus hairs, the other kind of hairs that cover the body, they tend to be shorter, sometimes pigmented, but they don't generally have a shape that tend to be soft and smooth. When you look them under the microscope, they do not have a center core. They do not have medulla. So when we look at the hirsutism score, we use this modified Ferriman-Galloway score. And the reason it's modified is that Ferriman-Galloway in their original report in the early 1960s had two more areas, the lower legs and the lower arms. But those lower legs and lower arms, we found out, and so did they, in fact, in their original report, that really did not correlate with the rest of the body. So you could have fairly hairy lower legs, but not be hirsute, right? You could have fairly hairy lower arms and not be hirsute. That's something we already know about. So the modified Ferriman-Galloway score has 9 body areas: upper lip, chin and neck, upper chest, upper abdomen, lower abdomen are often called male scutcheon, arms, thighs, front and back, upper back, and then lower back. And again, the way we score each body area and then we add them up is that, in fact, if it's 0, right, if there is no terminal hairs in that area, it's 0. If there's a little bit of terminal hairs, it's 1. If it's more than a little bit, but certainly not that of a man, it's 2. If it's 3, it's that of a man who's not very masculine, not very hirsute. And 4 is that of a regular man. And so that we tend to do this for all areas, right? Upper lip, etc. And then we add them up to get our total FG score or hirsutism score, right? And we should always do that. Now, we published a number of years ago an atlas of what it looks like, so that it helps you standardize your measurements. This is, for example, the upper lip and this lower abdomen. You can download this from the internet. This gives you a way to standardize your Ferriman-Galloway score. Now, the question that comes out is, okay, what is abnormal? How much is too much? You know, how much terminal hair growth in male areas? What is the FG score that is too much, and that we should then define women as being hirsute? Well, this is a study that we did a number of years ago where we compared hair growth in unselected women. These were women that were coming in for a pre-employment physical, not for any medical condition. There were 350 black women and 283 white women. And what we then found is a couple of things. One, the distribution of hair growth was very much the same in these two groups of women, in black and white women. The second thing is that, in fact, there was no abrupt cutoff. So when we did cluster analysis, this is a statistical test to try to find the natural cutoff. What you found is that the natural cutoff was 2 or less. So if you had a score of 2 or less, you had very minimal risk of having PCOS, very minimal complaints of excess hair growth. You did not use electrology very much, etc. If you had a score of 3 or more, then you had a 50% chance of having PCOS. You had lots of complaints about having unwanted hair growth, being hirsute, feeling abnormal, and also using electrology. So in this study, the cutoff is about 3. To define hirsutism. In other studies, it's 4 or maybe 5. We've done other studies, in fact, in Asia, and the cutoff in China, for example, is about 5, but it's fairly low. It's somewhere between 3 and 5 is the cutoff. That's why the international guidelines state that a cutoff should be about 4. Okay, so in fact, it is not 8 or 10, as many places use it. 8 or 10 really was done originally as a 95th percentile. Even Ferriman himself stated that that was not not appropriate, and in fact, he used a score of 5 in his studies. So I think it's important to understand what the cutoff is, and that the cutoff for Ferriman-Galloway is generally much lower than what we normally assume. Now, how about hormonal testing? Well, hormonal tests have 3 objectives. One of them is to test or confirm the hyperandrogenism. So if the patient comes in and her hyperandrogenism isn't very clear, she may not be very hirsute, she may not be hirsute at all, maybe she's too young, maybe she's too old, maybe she's a different ethnicity, etc. You will then need to get hormone testing to confirm hyperandrogenism. And again, we generally recommend a total of free testosterone using a very high quality assay. And you may also want to include DHEAS or androstenedione, although this adds only about 10% to the prediction of hyperandrogenemia. But the key here is this: the value of these hormonal tests are primarily in those women that do not have evidence of hyperandrogenism. The patient is hirsute or bearded, then there's not a lot of value in these tests. The second thing is, if you're going to actually use these tests, you need to use high quality assays. Direct immunoassays for testosterone and certainly free testosterone are generally very poor. They are very insensitive and very inaccurate, and we do not recommend them. We tend to recommend things measured by mass spectrometry, equilibrium dialysis, or high quality immunoassays using chromatography and extraction. The second type of hormone testing is to detect or confirm oligovulation. So in normal women who do not have hirsutism, if they come in and they state that they have regular predictable cycles, then that patient, right, generally is somebody who is highly likely to be ovulatory. But alternatively, if that individual is hirsute and says that she had regular periods, only 60% of those people will actually have ovulation. 40% will be anovulatory, and that's where you come in. So if the patient states that she has regular periods, you need to confirm that periods by measuring at least in one cycle, maybe 2 cycles, the progesterone level on day 22 to 24 of the cycle. And finally, you're going to use hormonal testing to exclude similar mimicking disorders. We talked about that. You're going to check a TSH to exclude thyroid dysfunction, which is a cause of oligoovulation in many patients. Hyperprolactinemia, again, a cause of oligoovulation. And basal 17-hydroxyprogesterone, which is a very good test to screen for non-classic adrenal hyperplasia of the 21-hydroxylase deficient type. The incidence of these varies on populations. In our populations, about 4% of patients will have abnormal thyroid function, 3% will have abnormal prolactin function, and somewhere between 1 and 3% will have non-classic adrenal hyperplasia. There are other tests that you can do, but these tests tend to be more specialized, and particularly tests that you tend to use when the patient presents with specific symptoms like cushingoid features, for example, or severe acanthosis nigricans, or they have an elevated basal 17-HP that suggests that they have non-classic adrenal hyperplasia. Now, AMH levels have been suggested as a measure for polycystic ovarian morphology. I will simply say to you that right now, there is a lot of overlap between different serum AMH levels, and we do not recommend it as a means of detecting polycystic ovaries in when you're evaluating somebody for polycystic ovarian syndrome. But it is something coming, and I think we need to keep an eye on it, and we should have better data in the near future. Now, if you look back at 17-hydroxyprogesterone, you will see that about 80 to 90% of non-classic patients have basal levels of 17-hydroxyprogesterone above 2 nanograms per ml, which is why it's such a good predictor. The basal 17-HP is such a good predictor of non-classic adrenal hyperplasia. It's important to try to do this in the follicular phase. This is a study in normal women, and you can see that basal 17-HP levels were much higher in the luteal phase. About 50% of the time exceeded this cutoff of 2 nanograms per ml, and so you tend to want to do these tests in the morning. So what I do with my patients who I'm evaluating for non-classic adrenal hyperplasia is I have them return to the clinic fasting in the morning right after an induced or a natural withdrawal period, and then I get all my tests at the same time, and I know that the tests are accurate and clean. Now, polycystic ovaries is one of the criteria for polycystic ovarian syndrome. And one of the things that has changed is the number of antral follicles that actually is to be considered polycystic ovaries, right? It used to be 10 or 12. Right now, it is 20 follicles in at least one ovary when you assess the entirety of the ovary. So first things first, you do not just assess the ovary in one plane. That is not correct. That's not the way you count antral follicles in an ovary. Secondly, you want to get at least 20 follicles or more to actually call that polycystic ovarian morphology by antral follicle count. Because, of course, our ultrasound today is much, much better than it was 20 or 30 years ago when that original definition came into place. Now, the volume, and you should calculate ovarian volume, the volume has not changed, so you can still diagnose polycystic ovarian morphology by increased ovarian volume greater than 10 mLs, and that has not changed. Family history, strong predictor of PCOS. That's one of the other great predictors. So if you have to have 3 questions really to ask your patient, you can ask them about her cycles. You can ask her if she has excess hair growth or anything that suggests excess androgens, and you can ask her about her family history. So again, family history, very powerful predictor of PCOS. No more powerful than it is for many other conditions, but certainly very powerful. Adolescence, well, there is no established criteria for the diagnosis of PCOS in adolescence. And, you need to always remember that the diagnosis of PCOS has lifelong implications. And the features of PCOS may be less well established in adolescence. So you can diagnose PCOS in adolescence, and I'll show you that data. But if the diagnosis is unclear, then the most prudent course of action is expected management, manage her symptoms, see how she progresses. Again, you do not want to label a young person as having PCOS because that has lifelong implications unless you're absolutely sure. This is a study that we did comparing adolescents with PCOS versus young adults with PCOS. And what you find really is that, in fact, there was very little differences in the presentation of the adolescents that we saw versus young adults that we saw with PCOS. So yes, you can diagnose PCOS in adolescents. But again, not all adolescents will be fully, that will have the full syndrome. For example, what we found, is that adolescents tended to have more acne and tended to have more regularity in their periods versus young adults, but young adults tended to be heavier, have greater body mass index than adolescents. Now, how about metabolic dysfunction? We do know that about 80 to 90% of PCOS patients have insulin resistance, and that's mostly due to adipose tissue dysfunction, some cellular and cell signaling defects, and of course it's made worse by obesity. That insulin resistance in PCOS, because PCOS women tend to be younger and tend to actually have a better pancreatic function, will result in hyperinsulinemia. And it is this hyperinsulinemia that actually causes a lot of the effects or a lot of the symptoms, signs and symptoms in PCOS. They will suppress, for example, hepatic liver production of SHBG. They'll increase ovarian theca production of androgens in combination with LH. All of this results in hyperandrogenism. So hyperinsulinemia is really the core issue in a lot of these patients. This metabolic dysfunction and hyperinsulinemia, of course, results in lots of other metabolic morbidities, an increased risk of diabetes, impaired glucose tolerance, endometrial cancer, dyslipidemia, etc. And of course, it's important to recognize it. One of the things that we have become aware of more recently is that, in fact, the severity of the menstrual dysfunction predicts the degree of insulin resistance. This is a study we did a number of years ago, and you can see that the severity of the menstrual dysfunction is almost linearly correlated to the severity of insulin resistance. So these are PCOS women with regular periods, and these are PCOS women who have periods every 3 months and then everything in between. So again, the severity of the menstrual dysfunction is helpful as a predictor of the severity of insulin resistance. And the same goes for hirsutism. The more severe hirsutism, the more correlated it is to fasting insulin HOMA values and the body mass index. In fact, hirsutism was the severity of hirsutism was actually better determined by the degree of insulin resistance and hyperinsulinemia than actually by the levels of androgens. And finally, phenotype is a big definer of insulin resistance. This is one of many studies, as you can see, where phenotypes A, B, and C, the hyperandrogenic phenotypes, tended to be much more associated with the risk of metabolic syndrome than was the phenotype D, the non-hyperandrogenic PCOS phenotype. So again, phenotype is very important in defining that. How do you evaluate patients with PCOS? Well, you can do a lot of things, but really the gold standard is a 2-hour oral glucose tolerance test for both insulin and glucose. And I'll explain why insulin in a second. But again, this is the gold standard. All expert societies recommend that patients with PCOS have at least one oral glucose tolerance test, a 2-hour 75-gram oral glucose tolerance test for glucose to determine impaired glucose tolerance. And we tend to also measure insulin, as I'll show you in a minute. Why is it important to do an oral glucose tolerance test? Well, PCOS patients tend to have good pancreatic function. So this is a study from our colleagues, Richard Legro at Penn State. And you will see that in green are the women who are diabetic with PCOS, and red are the women who had impaired glucose tolerance. And if you just use fasting glucose to actually determine that, for example, you use the ADA cutoff of 126 right here, you will find that you'll miss a lot of the diabetics. If you use the WHO cutoff of 110, you still miss some diabetics, and certainly you miss almost all your impaired glucose tolerance patients compared to what you would find if you do a 2-hour glucose tolerance test. So yes, you will need to do an oral glucose tolerance test for that. We tend to measure insulin as well because, again, we tend to view the finding of hyperinsulinemia is very important, particularly as you try to determine what's in best treatment for this patient. How long should you use drugs like metformin, etc. So we've have some general cutoffs, right? Mild hyperinsulinemia is a cutoff of 80 to 150. Moderate is 151 to 300, etc. So these are all important cutoffs that you should keep in mind. And finally, while we're not going to discuss in great length the treatment, treatment really depends on a couple of things. You want to suppress the androgens, bring them down. You want to block whatever androgens are acting on the skin in other areas. So you will use an anti-androgen, and you will then also work on improving the metabolic dysfunction of these patients, generally with things like weight loss, exercise, lifestyle modification, and metformin. In addition, if the patients are infertile, then of course you would proceed to things like ovulation induction, IVF, etc. But again, we're not going to talk a lot about treatment today. There's not enough time, but I just need you to be aware that PCOS treatment generally requires combination treatment and lifelong care and counseling. It's not a one-time thing. This is a lifelong kind of care. It changes over time, and you will need to support and help your patient. You need to be very aware of cosmetic treatments and how you may help your patient in this regard. And so these are complex patients that require good care. I very much appreciate your attention, and I'm sorry we only had a short period of time, but I'm happy to answer any questions you may have.
Thank you, sir. Thank you. It was such an informative and impressive talk. We wholeheartedly appreciate that you share your time and effort with us tonight. We will have a couple of questions. If you are in the connection, I would like to forward these questions to you. If this is not possible, we will collect all the questions and try to get the answers and forward the answers to the ones who have asked their questions.
All right, so there is a question here. Is there a new hormone marker that can be used in the diagnosis, treatment, and follow-up of PCOS patients? So the short answer is there's lots of research looking at hormone markers, AMH being one of them, for example. But to be fair, none of them has been really very useful as a single marker for PCOS. So today we don't really recommend anything unique. If you're following androgens, for example, you may want to check androgens and so on, but it's mostly the clinical response of the patient that is the most important marker. Of course, if you're looking at metabolic dysfunction, you would follow everything from hemoglobin A1C to the responses to an oral glucose tolerance test. But again, in answer to the question, are there any new hormonal markers? Lots of research, but to be fair, nothing specific. So the other question is, theca cell-derived BMP7 and 4 can be used to discriminate. So theca cell-derived BMP7 and 4 have been found to be elevated in patients with PCOS, particularly in theca cell cultures. Unfortunately, they're not very useful to distinguish between normal and abnormal, between PCOS and non-PCOS theca cells, and they're less able to distinguish between PCOS and normal individuals when measuring, say, blood samples, for example. So in general, to date, they are useful as markers to add into a potential research study, but not really as a clinical marker today.
Okay, instead of using oral glucose tolerance test, can we prefer to use HOMA insulin resistance test?
Yeah, HOMA, IR, and Quickie, and all of the other tests based on basal glucose and insulin levels are not very sensitive. They are used in research studies when we do epidemiologic studies, so large population studies, but they are not very useful in studying individual patients. So in fact, one of the reasons that all the societies that have looked at this recommend a glucose tolerance test is because it is the most sensitive test to detect both glucose intolerance as well as hyperinsulinemia. And that is because many women with PCOS, as I said, have relatively good pancreatic function. So only when you stress them can you actually detect an abnormality. We will try to arrange it for some time in the future, but thank you for having me. I appreciate it very much.
Okay,
Take care. Bye-bye now.
thank you.